Good afternoon. I'm Dr. Rajshekar Naik from Gunasheela Hospital, and I have with me Dr. Vasant, who is a senior consultant with me at Gunasheela Hospital. We both deal with male infertility in the hospital. In the last episode, we spoke about medical management, which is the giving medicines and hormones and injections to treat male infertility. And in this episode 5, we are going to talk about the surgical management, where we use some form of surgery to enhance male fertility, or we do some sort of surgical procedures, minor and major, to get sperms from the testis in certain circumstances, which we will come to during this talk. So, Dr. Vasant, next slide, please. Dr. Vasant, can you just briefly tell us the problems where the surgical treatment is used for male infertility?
Uh, Good afternoon. Few conditions require surgical intervention. Surgery, in few conditions, surgery is an option, and in few conditions, surgery is the treatment. So we have three conditions where surgery is commonly indicated. The first one is varicocele, the second is obstructive azoospermia, second one is non-obstructive azoospermia.
Now, when we say azoospermia, that means when we do a semen analysis, there are no sperms at all in the semen.
Yes.
That condition is called azoospermia. And there are two different types. We will come to that a little later. I think first we will just discuss about the varicocele, which is a very common condition affecting male fertility.
Yes, sir.
Can you tell us something about what is this varicocele? And we keep hearing about this. And why is it important to make a diagnosis of varicocele? And what are the advantages or disadvantages of treating a varicocele?
Yes. Varicocele is abnormal dilatation of veins in the testis. So, usually the veins carry the impure blood to the heart to get purified. In varicocele, there will be the defective valves. The valves are defective, and so the impure blood stays in the testis for more time. And this could be the cause for poor sperm quality. The other reason is it might increase the temperature in the testis. Even that could be the cause for poor sperm quality.
Yeah. Now, the important thing is that veins are the blood vessels that bring the blood back to the heart, impure blood, and the veins of the testes are called pampiniform plexus. And when those veins are not functioning properly, the impure blood stays in the testis for longer, increasing the temperature, increasing metabolites. And therefore, this is known to suppress or interfere with sperm production and sperm maturation. Now, this is a theory. And varicocele has been associated with low sperm count for a very, very long time. And although there are lots of studies talking about varicocele, the advantages and disadvantages, we apply it very selectively for treating male fertility.
Yes.
So, when do you decide that a patient actually needs treatment for varicocele surgery? We don't treat all patients with the varicocele operation.
Yes.
But when do you think the patient actually needs surgery, or when do you think the patient will benefit from having surgery for varicocele?
Yes. Any patient walking with the scan report saying varicocele doesn't require surgery. First and foremost is when we examine the patient, if we feel that there is varicocele on clinical examination, we confirm by a scan, and we take into several factors in before we advise surgery. We consider wife's age, wife's evaluation. Wife's evaluation should be normal or near normal before considering varicocele surgery. There is a condition called subclinical varicocele. That means patient, like usually we get patients from outside. Some doctor would have done a scan. The patient might be having varicocele on scan, but clinically, if it is not palpable, that is subclinical varicocele. That is not an indication for surgery.
So it is very important that the patient is examined by a doctor to confirm the presence of varicocele. When I say clinical, that means we do a physical palpation of we feel the varicocele. And if that varicocele is confirmed on scan, the benefit is only in this group of patients. It is not beneficial to do varicocele surgery in patients whose varicocele is diagnosed only by scan and not by physical examination. I think that is very, very important for us to know. And once we decide the patient has got a varicocele, we, like Dr. Vasan said, we go through a few issues. We look at the wife's status, whether she's normal, wife's age, and a whole lot of parameters. And then we discuss with the patient the advantages, what is the success rate of varicocele treatment, and then what is the treatment. Now, can you just tell us what is the treatment for varicocele?
it's a surgery. It is a minor surgery, not a major surgery. It is done in operation theater under anesthesia. There will be a small cut in the groin where we identify the dilated veins and tie and divide them. Most of the patients get discharged on the same day or the next day.
Can you tell us any negative things about the varicocele operation? Suppose I say that somebody has advised me varicocele surgery.
Yes, sir.
And suppose I'm convinced that it is going to benefit me. What are the problems associated with this operation? Are there any side effects in the short term or long term? I would
Yes,
like to know.
Yes, sir. They are not major complications. Minor complications can happen, which might be a blood clot formation or a wound infection, which is seen in less than 1% of the patients. And
Is it going to affect the patient's sexual life in future?
no, sir, there won't be any problem in sexual intercourse after surgery.
And there is no impact, long-term impact on the sexual health of the person. So there is absolutely no impact on the sexual health of the person after varicocele surgery. Now, what is the success rate? I mean, suppose somebody advises a varicocele surgery, is it 100% guaranteed or is it less than that?
Yes, sir. Suppose if you do surgery today, there won't be improvement tomorrow. It might take around 6 to 8 months to improve, or maximum up to 18 months. But usually we wait for 6 to 9 months. And the success rate is around 40%.
Yeah, that means if we do 100 operations on 100 patients, in 40 the patients, there will be a clear, definite improvement in sperm quality,
Yes,
and which may also lead to a successful pregnancy naturally, if the wife is normal.
Yes.
And also, not only the first child, even for the second child, they don't have to bother coming to the hospital because their semen quality is already improved, and they would not need to come repeatedly to the hospital for various assisted reproduction procedures if they are successful. So even if the percentage of patients being successful is less than half, but for that group of patients, that is the end of hospital visits for pregnancy. Now we would like to discuss about this condition called azoospermia, where the sperm count is completely zero. We have a lot of anxious patients coming and saying, "Doctor, I got this test done, and 2 of my tests have said that the sperm count is zero. Am I ever going to be able to father a child biologically?" That is the biggest concern. Now, can you just tell us a little bit about azoospermia, how we define it,
Yes,
and then how we go about classifying it?
Yes, sir. Azoospermia is the absence of sperms in the ejaculate. It can be due to obstructive or non-obstructive cause. Obstructive cause, here the sperm production will happen, but there will be blockage in the flow of sperm. In non-obstructive azoospermia, that means there is some problem in sperm production. So that's how we classify into obstructive and non-obstructive.
To tell you in detail, the sperms are produced in the testes and they are transmitted into the urethra through a pipe called the vas deferens. Now, the vas deferens is a thin, long 25 centimeter tube that transmits the sperm from the testis into the urethra and ultimately into the ejaculate. So, when there is any blockage to the transit of sperm from the testis to the outside, we call that obstructive. And when there is a problem with the sperm production itself, but there is no problem with the transit or the transport, then we call it non-obstructive. So these are two broad categories of azoospermia where there is no sperms in the ejaculate. Now, what are the causes of obstructive azoospermia, Dr. Vasan?
Yes, sir. Either repeated infection in the testis or epididymis can cause obstruction in the epididymis, or blockage of the ejaculatory duct, which is called ejaculatory duct obstruction. That could be the cause. And blockage, as you told, the pathway, blockage in any part of it can cause obstructive azoospermia. And sometimes patient would have undergone vasectomy. In those patients also, there will be an absence of sperm in the ejaculate.
Yeah. And any surgery in the groin where, as childhood or in adulthood, hernia surgery, and if the care was not taken to protect the vas deferens, which is that pipe I mentioned, then damage to that again obviously can cause a blockage and obstructive azoospermia. Now, can you tell us about the treatment? What do you do? Now, suppose somebody has got azoospermia, we do a clinical examination and we do relevant investigations, and we make a diagnosis of azoospermia.
Yes, sir.
Now, what is the treatment for these patients?
Yes, sir. When we make a diagnosis of obstructive azoospermia, there are some options. Suppose if there is blockage, then there is one option called reconstructive surgery where we bypass that block. So that is one. And suppose if a patient has undergone vasectomy, for unfortunate reasons they want to reverse that, then we can do reversal of vasectomy considering the wife's parameters. The other one is to retrieve sperms from the ejaculate and use it for IVF. So these are the options.
Yeah. Generally, the reconstructive surgeries have a fairly low success rate. And therefore, with the advent of the IVF treatment, in vitro fertilization, more and more patients prefer that instead of undergoing a surgery. They prefer to get the sperms taken out from the testes, which are obviously very easily available. But you just put a small needle into the testes, we'll get hundreds of sperm. And these sperms can be used for injecting the wife's egg, and where we do an IVF. So, reconstructive surgery or getting sperms directly from the testes. So, in obstructive azoospermia, like I said, reconstructive surgery is possible, bypass surgery is possible, but then we give the options to the patient to decide which one they want. We give them the success rate, the costs involved. By and large, most of the patients prefer to go for IVF, which they feel is a easier option. Now, when we talk about getting sperm from the testes, there are various ways of getting sperm from the testes, starting from putting a needle to take a chunk of the tissue from the testes. Can you just briefly go through the sperm retrieval techniques?
Yes.
How do we get sperm from the testes?
Yes. There are so many procedures to get sperms from the testes. One is biopsy. The commonest procedures which we do in our hospital is aspirate from the epidermis, that is called PISA, and which we aspirate from the testes is called TISA.
Yeah, basically what we do is like taking a blood sample from the veins. We put a fine needle into the testes and we just draw the fluid, and that will contain sperms. Obviously, because it is a testis, we would like to give anesthesia to the patient. We don't want to do it under local anesthesia because it can be very painful. So we give a 5-10 minute anesthesia to the patient, which is called a very light level of anesthesia, and then we put a fine needle and take out these sperms. And this is mainly done for obstructive azoospermia, where the production of the sperm is normal, but the sperms are not able to come out. Now, when we go to the next topic, what do you think are the causes of non-obstructive, where there is a production problem of the sperms? The sperms are not being produced in the testes, or even if they are in a very small area of the testis, and a very, very small number of sperms are being produced. And as a result, they are not able to come out. Can you tell us the various causes of non-obstructive azoospermia?
Yes. Sometimes infection in the childhood by a virus called mumps can lead to non-obstructive azoospermia, and sometimes genetic causes, and sometimes undescended testes. Usually in the fetus, the testis will be in the abdomen or in the stomach. Well, before birth, it gets traversed into the scrotum. So if the testis is undescended, then that could cause non-obstructive azoospermia. And sometimes patient would have undergone chemotherapy for some cancer condition that can permanently damage the sperm production because of the drugs used in chemotherapy.
So, in non-obstructive azoospermia, what we do is we do a complete physical evaluation, and I would like to stress again that physical evaluation is a very, very important part of evaluating a male infertile patient. It cannot be ignored. So, we do a physical evaluation of the patient that gives us an idea as to whether this person is producing sperms or not. And in addition to that, we do a few investigations to tell us whether this patient can produce sperms or not. Now, if there is inconclusive evidence that this person cannot produce sperms, then we give them various other options of donor sperm or adoption. But if there is a slightest chance that this person is going to producing sperms, then we must make all attempts to retrieve those sperms in these patients. And then we do a whole lot of testing, like genetic tests and a whole lot of tests, to see what are the chances of getting sperm in this patient from his testes. So if we get an idea that there is a chance of getting sperm, then we proceed to the next step, which is what are the options that we have, Dr. Vasan, to get sperms from these patients where there is a production problem?
Yes. Sometimes if there is some hormonal imbalance or hormone deficiencies, we give hormonal injections to boost the sperm production. And there are different types of sperm retrieval techniques, as we mentioned in obstructive azoospermia. Similar way, either we can do PISA, TISA, and micro-TIS. But when compared to all these procedures, micro-TIS has the best chance of sperm retrieval.
Yeah, the problem with non-obstructive is just blindly putting a needle, like versus in the obstructive case. You will not get sperm in these patients because, like I said, they are produced in very small numbers in various parts of the testes. So just putting a needle blindly, which is called a PISA or a TISA, is not going to yield sperm. So over the last few years, a technique called microsurgical testicular sperm extraction, that is removing the sperm using a microscope under magnification, has become a very popular uh, method of obtaining sperm from these patients. And now currently that should be the only procedure used for obtaining sperm in a non-obstructive azoospermia patient. That is micro TZ it is called, and that should be the only procedure that should be used because it gives you the highest chance of obtaining sperm in a non-obstructive azoospermia patient. Now, what is this procedure involved, Dr. Vasant? What do you do exactly? What do you mean by microscopic testicular sperm extraction?
Okay, this is a surgery which is done in operation theater under anesthesia. So here we use a microscope for magnification purpose so that we can identify the dilated tubules. Here the sperm production happens in tubules called seminiferous tubules. We just can't remove more seminiferous tubules and assess because seminiferous tubules also has other function like testosterone production. So our aim is to pick seminiferous tubules as less as possible and get the sperm yield. So this
Yeah,
magnification helps
yeah,
in
although it
getting.
appears like a big operation, this is the least likely chance of causing damage to the testis because under the microscope, we look at the blood vessels and without damaging the blood vessels, we very carefully remove very, very small amount of the testicular tissue which can hardly be seen by naked eye. And as these seminiferous tubules are removed, and then they are sent to the lab immediately where they process them and they tell us whether the sperms are available or not available. So this procedure takes about half an hour to 45 minutes. It's done under microscope with a magnification about 25, and then it is done under anesthesia obviously, and then most of the time the patient is discharged the same day or the patient can go home the next day, and the patient would require some rest for 1 or 2 days, not bed rest, but the patient may not be able to go back to work for 2 to 3 days. And the results of these tests are available immediately. The embryologist will tell us whether the procedure has yielded sperms or not yielded sperms. Again, the complications are similar to TISA. Sometimes very less than 1% of patients, you can develop some hematoma, which is a blood clot in the testes, or you can develop wound infection, which is very, very rare because we take sufficient care not to injure any blood vessels. And obviously, these are done under very, very clean circumstances in the operation theater.
Yes.
And what are the chances of getting sperm in this non-obstructive? In our experience, we have done hundreds of
Yes,
these.
yes.
So, what has been your experience in getting sperm which can be used for IVF ICSI in our experience?
Like somewhere between 45 to 50% of the patients we were able to retrieve the sperms
Yeah.
and use it for IVF.
Yeah, that is a very good number. In the days that we are doing only needle aspiration, only less than 15% of patients we were able to get sperm in non-obstructive azoospermia. Once we are switched to micro Ts, close to 50% of patients we are obtaining sperm which can be used for IVF. And they're good enough to be used for IVF. And I think in our center, whether the sperm was naturally ejaculated, obstructive azoospermia, or the sperms obtained from micro Ts, our success rate has been very consistent and it is almost the same across the three categories of patients. And that is a very surprising thing considering that the number of sperms that we obtain on micro Ts are very small.
Few.
And that probably goes to show how good our embryologists are in choosing the right sperm for IVF in our center.
Yes. Questions?
So I think we have pretty much covered most of the topics in terms of surgical management of non-obstructive azoospermia. Now, fundamental questions again, like we did last time. The biggest concern is, doctor, my semen analysis shows zero sperm count. So do I have any chance of fathering a child? I think we have discussed this at length. Yes, there is definitely a chance. Of course, the result is not 100%. But if we do, whether it is obstructive or non-obstructive azoospermia, if we get sufficient sperm with IVF, I think there is a very good chance, close to 60% chance of the person fathering a biological child of his own. I think that is very promising, and I think that's a very good thing. And I think people if their report comes as zero sperms, should contact a male fertility specialist, get himself evaluated instead of going here and there and trying for all kinds of treatment. I think it is very important for him to see a specialist who is experienced in dealing with this problem and then get a good evaluation done. And like I said, there is a very good chance that this person can father a biological child.
One. Yes.
It's very possible. We have done hundreds of these in this hospital, and I think it's very important not to go for other options before they have exhausted the option of looking for their own sperm and then fathering their own biological child.
Yes.
I think we have discussed this problem in fairly detail, but I think it's very important for patients to ask questions. And if you have any questions, you can ask at askgunasheela.com, and feel free to get in touch with us. And we'll be quite happy to answer any of your questions and help you in this journey of parenting a child. Thank you very much for your patient listening. I hope this lecture was very helpful. Thank
Thank
you.
you.